This video will focus on vision and vestibular dysfunction. The information has been provided by the Ontario Neurotrauma Foundation's Best Practice Guidelines for Concussions and Mild Traumatic Brain Injuries. Persistent vertigo, dizziness, imbalance, and visual disturbance are common symptoms of patients with a concussion or mild traumatic brain injury and are often associated with objective impairments of the vestibular system. The most common cause of post-traumatic peripheral vestibular dysfunction is benign paroxysmal positional vertigo, or BPPV. Patients experience episodes of vertigo, nystagmus, and nausea with sudden changes in position, often including rolling over in bed or looking up. These attacks typically last less than 30 seconds but can be quite disabling and occur multiple times per day. BPPV is caused by dislodged otoconia in the posterior semicircular canal. Individuals who experience dizziness have been noted to also frequently experience concurrent psychological disorders such as anxiety. These disorders may exacerbate the feeling of dizziness and as such should be managed along with vestibular treatments. Evaluation by an experienced healthcare professional with specialized training in the vestibular system should include a thorough neurologic examination that emphasizes vision, vestibular, balance and coordination, and hearing. The evaluation should be conducted prior to 3 months post-injury. Appendix 3.4 linked below this video can provide more information on specific examination details. When a patient's assessment suggests vestibular dysfunction, vestibular interventions can be considered. Vestibular rehabilitation is typically provided by a specialized healthcare professional and involves various movement-based regimens to bring on vestibular symptoms and desensitize the vestibular system, coordinate eye and head movements, and improve functional balance and mobility. In particular, vestibular rehabilitation therapy is recommended for unilateral peripheral vestibular dysfunction. When the history suggests BPPV, posterior semicircular canal involvement can be diagnosed by the Dix-Hallpike Manoeuvre once the cervical spine has been cleared by a qualified healthcare professional. More information about this maneuver can be found on Appendix 10.2 and Appendix F for a video demonstration. For maneuvers and treatment, the patient should be referred to an otolaryngologist or a healthcare professional certified in vestibular therapy. A canalith repositioning maneuver should be used to treat benign positional vertigo if the Dix-Hallpike Manoeuvre is positive. The Epley maneuver should be used on patients with positive Dix-Hallpike Manoeuvre for both subjective and objective BPPV. This maneuver can be found in Appendix 10.3 linked below this video. Vision changes can occur post-injury and should be screened for. If symptoms are reported, the healthcare professional should take an appropriate history and complete a visual examination. Appendix 10.4 may be used to help with screening individuals. Patients presenting with vision disorders post-injury may present with several different vision dysfunctions, including but not limited to impairment of visual acuity, accommodation, versional and/or vergence eye movements, visual field integrity, and occasionally photosensitivity. Depending on how their visual symptoms present, patients who have suffered from an injury should be referred to the most appropriate healthcare professional. For example, patients with complex visual symptoms such as diplopia and/or impaired vision should be referred to a neuro-ophthalmologist, while those with impairments of accommodation, version or vergence movements, or photosensitivity may benefit more from rehabilitation techniques by qualified optometrists. For further information regarding vestibular and vision dysfunction, you can refer to Section 10 of the Ontario Neurotrauma Foundation's Guidelines for Concussions and Mild Traumatic Brain Injuries and Their Persistent Symptoms. Special acknowledgements go out to the Kinesiology Department at the University of Waterloo, the Centre for Community, Clinical and Applied Research, and the Ontario Neurotrauma Foundation, which provided the funding for this video.